First, I'd like to talk about the background and updated outline result of thyroid cancer screening. Thyroid examination in the Fukushima Health Management Survey. Next, I'd like to explain the international recommendations against thyroid cancer screening. Finally, I'd like to present the lessons learned and make proposals for conducting disease monitoring as countermeasures following a nuclear disaster. It is well known that thyroid cancer increased among children after the Chernobyl accident, mainly due to internal exposure by milk contaminated with radioactive iodine. A dose-response relationship between thyroid doses and relative risk thyroid cancer was reported, as shown left panel. Owing to various countermeasures to reduce radiation exposure, thyroid doses in Fukushima resident, as red arrow range, was deemed to be much less than in Chernobyl, as blue arrow range, suggesting that is unlikely to have produced a detectable excess of thyroid cancer incidence in Fukushima. However, residents have been concerned about potential increase in thyroid cancer. So, even if low dose of radiation exposure and not enough evidence of thyroid ultrasound screening, thyroid examination was considered to be useful as a countermeasure in disaster zone. This is not only for building scientific evidence as health surveillance, but also for responding to social demand to address anxiety. Though thyroid cancer screening as Fukushima Health Management Survey was started in October 2011, soon after the accident. The live photo was taken in the early days at the examination venue. Many people were waiting to receive examinations. This slide shows the flowchart of the thyroid examination in the Fukushima Health Management Survey. The subjects of thyroid examination include all residents aged 18 years and younger at the time of the accident in Fukushima Prefecture. The thyroid examination consisted of two stages: primary screening and confirmatory examination. The primary screening focused mainly on nodules and cysts using ultrasonography. Primary screening has been conducted at school during classes for 6 to 18 years old, and at the regional examination venue or clinic for other ages. The results of the primary screening were classified into categories A1, A2, and B. Category B included subjects for whom the confirmatory examination was recommended, as shown detecting nodule 5 mm over or cyst 20 mm over diameter. The confirmatory examination has been conducted at the particular regional hospital. Notably, findings such as nodule cysts are commonly observed in healthy people. The cases diagnosed with malignancy or suspected malignancy in the confirmatory examination are referred to the designated hospitals. The left two figures are distribution pattern by age at the time of accident, where the number of detected thyroid cancer cases was adjusted according to the number of examinees. This pattern increased with age in both the first and second screening rounds. This pattern by age at the time of accident differs from the finding with Chernobyl. There was a higher frequency of cases at younger ages with relatively short latent period after the Chernobyl accident. The right figure shows distribution pattern of incidence by age at the time of screening in the second round also increased with age. The increase of cancer detected by screening for the age group of 18 to 20 years was approximately 50 times compared with that of National Cancer Registry, mainly non-screening condition. The level of thyroid radiation dose in Fukushima is thought to be much lower than that of Chernobyl. The upper figure from Williams' review represents the age distribution of Chernobyl cases. Consistency with age-dependent radio-oncogenic sensitivity, younger age at the time of the accident was a higher frequency of thyroid cancer cases during 11 years after the Chernobyl accident. In contrast, the age distribution of ultrasound-detected thyroid cancer cases increased with older age in Fukushima, as shown in the lower figure. Though a relationship between a large number of thyroid cancer detected and radiation exposure was considered highly unlikely in Fukushima. These data and other reports are suggesting potential overdiagnosis due to ultrasound screening. There are two hypothesized patterns of thyroid cancer's progression. One is the exponential cell growth pattern, and the other is growth arrest pattern. If the tumor grows linearly and takes several years from ultrasound detection to clinical symptoms, the number of detections in the second and subsequent rounds should return to an unscreened level. High detection rate in the second and subsequent rounds may not suggest a linear growth of tumor. As shown in the left upper figure, the tumor growth rate was positive in the small tumor. In contrast, it was almost zero in the large tumor. These data suggest that most cancers were regarded as growth arrest patterns, even after showing early growth, as indicated stimulation in the left lower panel. Recently, a long-term analysis of active surveillance was also reported by Miyauchi et al. Growth arrest pattern after a similar initial growth phase at young age in the right lower figure. An European research group, Shamisen, reported the recommendations and procedures for preparedness and health surveillance of population following radiation accidents. The report indicated that systematic thyroid cancer screening should not be recommended, but that it should be made available with appropriate counseling and on a voluntary basis. Next, an expert group at the WHO IARC has also reported about thyroid health monitoring following nuclear accident, and it made two major recommendations. First, it recommended against population thyroid screening. Second, it also recommended that consideration should be given to offering a long-term thyroid monitoring program for high-risk individuals more than 100 to 500 millisievert exposure. These two recent reports were written based on the experience in Fukushima and Chernobyl, and they included the negative psychosocial issues of thyroid cancer screening. What are the differences between the screening and monitoring programs? The objective of screening is to reduce mortality by early diagnosis with public health benefits outweighing the harms. That of monitoring is to empower high-risk individuals to make an informed decision. Thus, the screening must be active recruitment and the monitoring must be passive. The recruitment goal of screening is generally to achieve high participation. In contrast, monitoring is not to aim high participation but to share decision-making between family and clinicians. The thyroid examination should be done as a monitoring in the context of the program. However, the approach of sending documented-based informed consent from the prefecture and university to all possible subjects and ultrasound examination at school is not the monitoring program, but screening program. Unless the situation is after the nuclear accident, thyroid examination would not have been conducted. Even if low-dose radiation level for residents, nuclear accident causes concern about various direct and indirect health impacts. It is often considered that various types of intervention are needed depending on phase of disaster cycle as shown in this slide. In initial response and recovery phases, environmental dose monitoring, radiological screening, and individual dose monitoring with the whole body counter or dosimeter are required. It is necessary to provide appropriate dose monitoring information to potential affected individuals quickly and carry out necessary intervention to protect against radiation smoothly. Though intervention through environmental monitoring may require timely information disclosure, sometimes low-level evidence. In the recovery phases, it is generally thought that health surveillance, like the Fukushima Health Management Survey, is advantageous to provide scientific data and also for communication with residents. However, recent Nature article shows that disaster zone research often induces ethical dilemmas and needs a code of conduct. Actually, large-scale thyroid mass screening in the Fukushima Health Management Survey resulted in cancer diagnosis from a large reservoir, even in young age. Contrary to initial expectations, this screening survey has also caused anxiety, and confusion among residents. To prevent the harm of overdiagnosis, a change of the strategy from screening to monitoring will be urgently needed, according to shamisen or WHIR recommendations. Compared to the environmental monitoring on the left side, the countermeasures for human disease on the right side require more necessity of code of conduct, such as human rights and personal information protection, and based on voluntary participation. Therefore, we propose that ultrasound screening is not first. A monitoring system that includes individual health consultation should be implemented to support decision-making based on the harm-benefit balance and pillar of the response to health concern among the population after nuclear disaster.